Good morning. Thanks for joining. Before we begin, I'd like to acknowledge the traditional owners and custodians of the land that I'm presenting from. That's the Bindal and the Wulgurukaba people, as well as those of the respective lands of everyone in today's call. I acknowledge their continuing connection to land, sea, and community, and pay my respects to elders past, present, and emerging. To those of you who are joining us for the first time, welcome to the Digital Champions Network online workshop, where we hope to deliver helpful tutorials and educational sessions, present virtual services, which will be accessible via telehealth carts, and provide a platform for peer discussion on all aspects of digital health as it applies to aged care. As this is a community, we do encourage cameras on, mics on, and ask if all participants would pop their name, role, and aged care home into the chat box so everybody gets to know each other. And the first item on our agenda today is just our speaker, Helen Hayden, Dr. Helen Hayden, a Senior Research Fellow for the University of Queensland Centre for Online Health, with special interests in telehealth, palliative care, dementia and aged care, also a registered psychologist with significant clinical experience. And I'll hand over to Helen for further introduction and to take the presentation away. Thanks.
Thanks, Kieran. All right, I'll share. Sorry, didn't realise I was sharing before. Okay, just assuming everybody can see that and can hear and see me okay. Great.
Can see.
Excellent. Okay, so as Kieran said, I'm Helen and Research Fellow and Psychologist at the Centre for Online Health, which is part of the University of Queensland. And I'm the theme leader of a palliative care stream there, but do a lot of aged care work as well. And today I'm just going to give you an overview of some projects and programs of work that might be relevant. Some you may already know about. And then, yeah, and if the slides, I'm happy to have them available in PDF form, but also if you need any further information, please reach out and my slide at the very end has all my details. So I would also like to acknowledge the traditional custodians of the lands upon which we're all meeting today. For me, that's the Yagara and Turrbal people's land, and pay my respects to elders past, present and emerging. So as I say, I'm from the Centre for Online Health, and so we're a research centre that's very practical in terms of we have a research arm, a consultancy arm, and we're part of a health services research centre as well. And what that means is that we look at health services and the implementation of them and evaluation of them, you know, how things are working effectively or not effectively, where the barriers are, what we can do to help. But our part is very much around virtual healthcare. So today I'll often use the term telehealth, but what we mean by telehealth is a broad definition. It's things like video consultations, telephone, remote patient monitoring, a whole range of things. Online, you'll see one of my projects is an online intervention, which is more like our website, I guess. So that's who we are here. And I've got an amazing team here, all of which all our researchers have clinical background. So that really helps us to know that we're not sitting in our ivory towers and dribbling things that aren't relevant, to put it eloquently. So this looks like a lot, but I will whiz through some of these sections, but this is just to guide you. So I'll sort of show how my work maps into some of the things that are existing services, Queensland Health Services. So you may have already heard or been using Sparta, and then the flow-on for that is the Sparta Grief and Bereavement Service, and then how that then clicked over into a national service that I run as well, which is called Palliative Care Echo. And then finally, we'll talk about my online intervention for carers of someone with brain tumour. So a lot of these are going to be relevant for you because they might be something that you use with your residents and their families, or it might be relevant to you in terms of you being a health professional and maybe it's a bit of training or maybe there's something there that's of use for you as well. So to start off, let's talk about Sparta. I am going to quickly have a look. So can I just get a show of hands, or I don't know if you know how to do the raising hands, who here has heard of Sparta and or used Sparta? So that's the Specialist Palliative Care Telehealth Service. Yep, great. So that goes across the state. Thank you. That's Queensland Health's one. Has anyone heard of Sparta Grief and Bereavement Service, which is a bit of an offshoot of that? Okay, so they're also underway now, and they've mainly commenced with a bit of training for health professionals around grief and bereavement, but we'll get to all of the detail of that in a tick. So for those that haven't heard of Sparta or don't use it, I'm going to do just a quick introduction about why that's there and what that looks like. So it all came out of, which you may or may not know if you've read the Royal Aged Care Commission as well, there's a need to increase the way we do, improve the way we do palliative care, and that's across the board. It's not just in aged care homes. So, for example, as you're probably all too aware, it's just another one of those health services where the majority of people, physicians and health professionals, are based in cities. And the further you go away from the city, the less likely you are to be able to have that specialist support. So in answer to the call out and in answer to that need, Sparta was born. And so the reason, actually, where's did I map into it? Oh, no, I didn't. Okay, I'm going to jump back a few slides. But so Sparta was born, and that is a Queensland Health telehealth service, and you can see that there's hub sites at Gold Coast, Sunshine Coast, Townsville and Cairns, and they then do video conferencing and phone, for example, out to regional, rural and remote areas as well. So for people that have used, and that's into aged care homes as well as into the community. And where I came in there is that we led the evaluation of that service to see how effective it is, and then sort of contributed to their reports back to Queensland Health to get to, and that contributed to them getting recurrent funding. So they're funded ongoing now. Here's just one example that looked at the costs of their service. There's quite a few other papers that we are. So I'll talk about academic papers, but they also translate into different reporting and things like that. And then in terms of recommendations for a service to go, well, this is where you've got a barrier here. This is where it's not working. This is what you need to do to fix it. So that's the sort of thing we do for our evaluations, as well as write academic papers. So we've got a few more papers up my sleeve. It's one of my things to do this year is to get those out. And as I've already mentioned, from Sparta service, the thing that, and you may or may not know all of this, so forgive me if you're already knowledgeable about palliative care, but one important component of palliative care, and obviously close to my heart as a psychologist, is grief and bereavement support. And it's often the thing, though, that gets left behind in palliative care. So we had I can't remember her name, Kim someone. So they started to go, there was a few social workers that worked for Sparta, and they said, okay, we need to push this out too. Again, same story, we need to get services and support out to people in rural and remote communities. And so the Sparta Grief and Bereavement Service was born. I'm not sure whether they've got recurrent funding, but that service is sort of twofold. The first thing it's done at the moment is done a bit of an audit to see what's going on across the state in terms of what are health professionals doing in terms of follow-up or in terms of an anticipated grief for, say, residents or older adults or the families of people who are palliative or sick. And so they're trained, so they've done an audit to see what health professionals are doing. They then have now been delivering a training course to upskill people in grief and bereavement support. And then at the same time, so I think that training is going to be ongoing, but at the same time, they're also delivering services. So same thing again. So for example, my PhD student is one of the social workers up in Cairns, and she delivers services out through the Torres and Cape and Cairns and Hinterland HHS, and vice versa in Townsville. So there's social workers at all of those hub sites. So we're involved there in terms of helping them analyse that needs analysis to see what's going on, and we're evaluating their training as well. And also then, so if you have done the courses and you've done the surveys, that's probably a survey that's been developed by us, and to find out what else we can do where other training is needed, for example. And then hopefully I'll get some funding to help evaluate their service as well. And that's from the patient perspective. So if we go back to the original Sparta, what was happening in terms of me evaluating that service, and I say me, I've got a whole team of people here that support that, is we were hearing time and time again. So one of the things I did is interview the health professionals that were out in community. And the thing that kept coming up more and more is that they wanted to learn more about palliative care. And because of the distances as well, I started to think, okay, there's a model here that we can do, and I'll get to, and that's called Palliative Care Echo, and I'll explain what that means. So I wasn't alone in realizing, wow, we really need, people are really, really wanting to upskill in palliative care. It's also, and amongst these major reports from the Department of Health and Aged Care from federal government, as well as Queensland, a whole bunch of other peak bodies all recognising the need for that. And so one of the things that I suggested and really wanted to could see of value, because there's a few things out there, there's a few sort of online modules you can do in terms of learning about palliative care. But we are an accredited, the Centre for Online Health where I work is an accredited provider of this thing called Project Echo. And I'm not sure if people know what that is, but basically it started in the United States, and it was all about, rather than moving patients and moving people all the time to the big smoke, let's upskill people in their local communities, the health professionals in their local communities, so that, because they're the best place to do this stuff, because they've got that local context. They know the people, they know the services. So the idea is to move knowledge, not people. That's the motto for Project Echo. And that works because you can see here you've got like a specialist team. So in my case, palliative care specialist multidisciplinary team. And you've got then all the people that Zoom in. So these are done by 1 hour Zoom sessions each month. And so all the health professionals it's now across the country, jump on. And the aim is mainly to get rural and remote health professionals to jump on and to listen to a 10-minute presentation by the multidisciplinary PAL care team. And then there's lots of discussion. So the discussion means that people are learning across. So if the palliative care specialist team in, Sydney, for example, says, oh yeah, you just go down the road and you get a CT scan, you might get a bunch of people going, actually, we don't have a CT scanner down the road. And so then there's people that have that shared understanding of resource problems, and there's a whole bunch of things. I've heard some amazing stories about fixing things, I guess, or addressing those gaps in resources. So, for example, even there was one story about how this person there was this old refrigerator or something like that was unused, big refrigerator, and they use that as sort of like a makeshift morgue for the time being. There's a whole bunch of things that can occur, but basically it's that normalization, that nice connection. And the thing that happens when we have our 1 hour Zoom sessions each month is that people talk about that professional isolation, and then it's that sharing of the knowledge, but it's also sharing of experience. So I think what's more valuable than the multidisciplinary team giving a presentation is the sharing amongst the local primary healthcare professionals. In the second half of that 1 hour, one of those primary healthcare professionals brings a case for discussion. And again, that whole learning loop, they call it, happens there. So it's shared learning. And ultimately, the specialist teams in the cities are learning about what's going on the ground as well. So it's incredibly valuable. As I say, our centre is an Project Echo provider, and you can see we've got quite a few on the go at the moment. So CRCNA, I don't know if you have much to do with them, but they are supporting us to deliver telehealth skills ones and a mental health one as well. I do have a partnership with Nacho, and we deliver Elder Echo as well, and that's aged care for the elder care support workers in different ARCHOs across the country. So as I say, so Project Echo is an international program, and so you can see the dots here. 22 countries are currently running palliative care echo sessions, and you can see where this one on the corner there of Australia, where's my little ticket there. And so there's 186 palliative care echo sessions, and that was of December last year, I think it was. So what does it look like? So I've given you that. Here's just an example of one of the agendas. So if it happens I think it's the third Tuesday of the month at the moment. And so we start off and you'll have, say, for example, for this one, it was Dr. Ofra Freed, who's the pelvic care specialist at Townsville. And so you may have come across her. And she was doing a presentation on clarifying goals of care. Everyone discusses, and then someone else delivers a case presentation. So part of the main things, rather than like a webinar type thing, the benefits of the ECHO model is that it really is about that local context. So it really takes that into account, the local context of the patient. And it gives people that backwards and forwards access to specialists though, and also, but it does promote that community of practice. So for example, for our evaluation, this is the research part of the palliative care ECHO. One of the questions we ask is about professional isolation and what impact that might have on people's professional isolation. So it started out, I'm going to race through this because it's not that important in a way, but it started out, we got funding, the University of Queensland gave me funding to run an ECHO, palliative care ECHO in Queensland. And then a year later, and so we had all these people in, so we were doing supposedly a Queensland one, and then we had people from Tasmania, we had the Pharmaceutical Society of Australia saying, can we please access it? So the whole thing is free. And so from that, then we put in an application and got federal government funding for an Australia-wide palliative care ECHO. And these are just a couple of many that are our partners. So if you do go to that website, you can register to attend, as I say, monthly sessions. We don't record and send out those because the ECHO model is that people appear live. So if you're anything like me, I go, oh, can I watch that recording later? And then I never do. So the idea to encourage live interaction is to not share those recordings, and that's part of our agreement with Project ECHO in the United States. So we don't share the recordings, but do jump on and register, and hopefully you can come. But either way, you can see there's sort of different tabs here. There's a whole bunch of resources, and now we've got national resources, Queensland resources in each state and territory. Here's what's happening over the next. So we've got an archive where there's lots of, again, we always put the presentation slides up as well, but this is what's ahead of us this year. There's a couple of little changes. So I'm reaching out to different multidisciplinary teams across the country. There will be some changes June, July, because it's probably less relevant to you guys if you're working in an RACH. But there's the new federal scheme about keeping people at home and the end of life support at home. And so we're going to probably slot one of those in the June, July, one of the June ones instead. So, but that's just to give you an idea of what's coming up. This is the sort of reach we've had. This is, this is from November 2024. Last week, we had our voluntary assisted dying one topic, and that was a panelist from all over the country. And we got about 244 people come then. And so I'd say the reach is even more. You can see lots of people coming from the NT. It's big. So at the moment, there's really big numbers coming, which is a little bit unwieldy. It's not because it's good because I have a whole team of people that jump on with me and support, and people use the chat a lot to discuss as well as live discussions. But the idea is to maybe make it a little bit more contained, a bit smaller. So I'm currently waiting on some, I've applied to different funding to sort of so that we can have a RACH focused one as well as a GP focused one as well. So, and if we start to duplicate that, it means it'll get a little bit more containable. But do come along and give it a go if you do get the opportunity. And what you can do is you register on the website and just keep registering for all of them. And if you come, you come, and if you can't, you can't. So I'm not going to go too much into the researchy thing, but basically what we're hoping to do with this sort of stuff is increase people's palliative care knowledge, their confidence to look after someone who's dying, as well as their, again, that sort of social isolation, to see whether it helps in terms of building a community of practice. You can see here that the attendance was going up, so that's up until June last year, and it's pretty much remained quite steady. So you can see July 23, it was only about 30 odd people. As I say, the plan is to put on more so that we can distribute those people and it becomes a little bit smaller. But it's still, I think, from our feedback, lots of people are saying that they get a lot out of it, which you see here. So 80% of the people that have done our surveys have said that it has increased their palliative care knowledge, it's increased their confidence, and it's decreased professional isolation in those who report being potentially professionally isolated. When we ask people what it is that they found useful, people are incredibly effusive about the program and saying things were useful. They really liked the case. So the thing that comes up time and time again is the case studies. They really enjoy those case studies because they're incredibly practical. What was least useful? Most people struggled to say things were least useful. Sometimes there was a beeping where people would join and it kept tinging, so we got rid of that, which was good. So again, we get this feedback on board and try and change things where we can. But these results sort of aren't surprising because, as I said, there's an international project, so it's tried and true across the world. The final program I'm going to talk about is quite separate to all my other palliative care work. It's an online intervention or website, I suppose, called Caring for the Carer. And that is just something that you could potentially recommend if anybody has a brain tumour in your residence, or just if you know, these are just, so this is a project where we worked with some clinicians in WA, and they were delivering this sort of psychoeducation, we would call it. So they were delivering all this information and resources to people in their community. It was really well received, but again, really isolated around Perth. So we got funding to put it online. And so if you go to the Caring for the Carer website, there's a whole bunch of information and resources that are applicable from across the country as well, again, for carers of people with brain tumour, because even though it's only, thankfully, a smallish proportion of the country, there's a lack of information and support there for people, whereas this can give people information about what to expect if someone's got a brain tumour. And what was interesting, because a lot of my history and research is in dementia work, and there's lots of parallels there with dementia. It's not the same, obviously, but in terms of not knowing how the trajectory of symptoms, not knowing how they will act or what will happen for that person, where the loss of memory goes, for example, it's similar to brain tumour because the brain's so complex, we don't know what it's going to look like. So how do we support people who are supporting others as well? So that's just the Caring for the Carer website, which has been piloted by carers and evaluated by a whole bunch of carers as well. And that's about it from me. So I'm happy to, as I say, distribute these slides. That's my contact details there. I think that QR code is actually to get onto the website of PalCare Echo. And there's the generic PalCare Echo email. I haven't got my email's there if you need to contact me about anything. So happy to answer any questions or send any information out if you like. I think that's it from me.
Thank you for that, Helen. That was incredibly wonderful. Really appreciate it. And I'll make sure those contacts and everything on that last slide, and even the slides themselves, if you send those through, you said, I'll make sure they're accessible to anyone who wishes to peruse those after this. Looking to make sure as well, I might do a little bit of a piece in our newsletter on Sparta, and I'm always looking to promote the Echo sessions and even those telehealth skills Echoes touched on lightly there. Go out through the newsletter. Does anyone have any questions for Helen at all? Very rich background there. Look, I might go a little bit on almost a little bit of tangent here, I suppose. Not quite content covered, but I'm very interested a little bit in that psychology element of your background there, and if you just had any commentary on how to best engage someone, using telehealth, how the digital champions here might be able to maybe best utilize the telehealth equipment they've had, and just basically promote the best environment for helping their residents navigate the palliative care end of life experience when telehealth is involved. You had any thoughts about that?
Yeah, that's the $100 question. But there's definitely some thoughts and research and evidence around it. So the main thing we know, the big picture, is that mostly across the world, consumers, residents, patients, families are all very much in favour and very open to telehealth, because for a whole range of things. It can be convenient, it can mean that they can see mum or dad if they're not on campus, if they're away. It means they can all join together. It means that the clinicians or the health professionals are more acceptable. So usually it's not a hard sell to consumers. The hard sell, and probably Daniel, you'll both probably back me up, is for health professionals. And so partly that's about fear of changing the way things are done, or fear of being seen to be incompetent. There's a whole range of things that go on there. Also, because it's like any change, it can take a little bit more time. Picking up the phone is something we've all done for a long, long time, so it's much, much easier. Whereas if you talk to like the Sparta mob, they are 100%, there's no substitute for the picture, because I can see pallor, I can see movement, I can see a whole, it just is totally different. And so I guess, so I think, firstly, and I can send you this, there's a paper we've got, and I know it sounds all very ivory tower, but we've got this research paper, and it looked at psychological barriers for health professionals and what their concerns were. So in fact, there's two, I'll send both. One was from a psychology one from ages ago, and that has recommendations in it. And the other one has, which you might have received a lot of that training anyway. I think there's overlap with some of the stuff that Vision Flex does in their trainings and things as well. And the other one is this more recent, is about psychological barriers that health professionals face. But to answer your question, I think the main thing in terms of selling it to a resident and their family is to know, as the health professional, what the benefits are of telehealth. So I know this is fantastic. You don't have to leave home. This is fantastic. We can have the doctor Zoom in. We can all be in the same room and talk about this happening. There's the other thing is, and so the more knowledgeable the health professional is and more confident they are, that confidence comes across. If you've got a health professional on the other end of the line, for example, and going, oh, this bloody technology, I don't know what I'm doing, that's not going to instill confidence. So you've got to really, even if you fake it till you make it, express that confidence. The other thing, there was something else I sort of lost. Handouts, things like that, just to simplify it, so making it really nice and simple. But the other thing, partly, which we sort of always tell people as well, is, so if I have got an adult daughter on the other end of my call, that's the other thing, the assumptions, the other end of my call, then it's okay for me to go, Shireen, can you just move your light away a different way, or can you pull those blinds down, or I can't see your face, or whatever, and to really direct them and support them. And you're always checking that people can hear and see you clearly. Third thing really is have a backup. If the video is not going to work, if they've got really crap internet, they can phone and you have that backup. So it's about really having a lot of those telehealth skills and knowledge if you can, and then it becomes business as usual. My final thing is, which is one of my biggest bugbears, is there's a whole lot of assumptions out there and prejudices about older adults and what they can and can't do in terms of technology. 2020, COVID, we saw across the country, across the globe, all of these older adults using Skype every 5 seconds to reach out to their family, using, well, probably not Zoom, but Skype and all, fake WhatsApp, all of those video things. Video conferencing things. So there's a level of knowledge there, but there's assumptions that older adults can't do it. And yes, their digital literacy is not as good as the younger adults, but it's still definitely, the point is to ask and not assume. And then my final point is around assumptions. I've heard amazing doctors who work very closely with First Nations community say that it's not culturally appropriate. We have lots of evidence to say that that's not the case, that it's actually very culturally appropriate. If you think about things like palliative care, it means that people have more likelihood of dying on country rather than being shipped off to a hospital. It means that they can be in an AMS where they've got the support of an Aboriginal health worker to advocate for them. It means that they can stay in community. So there's a whole bunch of reasons that video conferencing and telehealth can be quite culturally appropriate too. So there you go. Yes. You asked me that question. I'm like, what?
No, I didn't want to stop you. Those final points just kept those pearls of wisdom really coming through. I think that was all very, very practical advice for the digital champions in this community, who are leading the engagement with their doctors, with their residents, and even with their peers. The other basically clinical staff within the aged care homes are part of that maybe resistant crowd. And these are the guys here who are responsible for kind of selling it and coming up and prompting those practical solutions.
Yeah, hats off to you. Excellent. Thanks, Hannah.
Anyone else, feel free, of course, to come off mic if you wanted to take advantage of Helen's knowledge and experience here. There's some excellent stuff there you can ask.
Look, I won't ask a question, but I'll back Helen up. The booking of regular sessions we've found has been a really good way for people to sort of build their confidence with the carts. Like you said, this is all still relatively new for most people, even though you've had the carts for some time now. And palliative care is another example of how these can be really beneficial to be used. Like we've had speech pathologists and dietitians love the carts, and doing admissions for emergencies, and this is just another good old quiver in the bow sort of thing to consider. But yeah, great information, Helen, and I couldn't agree more. It's just a matter of using it as gently as you can to just continue to build your confidence, start adding things on and start using it in different ways, and it will become the norm at some time. It's just when, basically. So yeah, hats off. But here to help.
It's like, use it or lose it. So even if you don't have doctors that you're going to be using it with at the moment, just keep practicing amongst yourselves. Have your own community of practice or something between you all as well. Share your grievances and things via it. Set some things up. Definitely keep using it.
And we're here to help with trainings. We're more than happy to do multiple trainings and do a couple of practice sessions exactly like that as well if you're having trouble to pin anyone down. But even try to do it with your relatives for a giggle one lunchtime. That's a big thing. A lot of good instances as well, even just having distant relatives. It might not even be palliative care. It's just get a relative on and have a chat. And that'll help break the ice as well. And that's a nice, calm situation to be doing it in. It's not like some emergency or some heavier type of a situation. So sky's the limit, really.
Yeah. And
confidence is key.
It is. And it's like any skill, isn't it? You practice until it becomes comfortable. So, and then you don't have to think twice. Yeah.
Deb, Merrin, I see you there coming off camera. Hello. Did you have any words to say? Any questions or just commentary on? And just on mute right now.
You are on mute, yep.
Yeah, as you were saying, Helen, it was a nice presentation. It's really informative. Thank you for that. We actually had a family discussion yesterday with the telehealth card through Health Direct. It was 2 family members involving with the GP as well. We had some changes in the residents, so we were discussing that. It went well. It was really good. They all no issues in turning on, or they were happy to participate. We 5-star rated everything, so it was actually good. So yeah, looking forward to include palliative care into it as well going forward. Yes.
Excellent. Well done, because I tell you what, GPs are the hardest nut to crack. So, you know, there's palliative care, telehealth services, there's geriatric ones, geriatrician ones. GPs, 90% of their telehealth is via phone. So they are hard. So again, so we're currently, another project I'm involved in, I'm not leading this one, is for Brisbane North PHN, and we're doing what we call the business processes for the aged care homes in Brisbane North PHN, and that's all about that stuff of how do we get other health professionals like GPs involved and things like that. Is there something we can send them to go, here it is, this is really easy? And Health Direct's great, isn't it? It's very user-friendly.
Just to clarify, GP was there with us, like he was not logged into. So he was there with us in the home, and it was just a family who had came up online through Health Direct link. So yeah.
Excellent. Well done.
Thank you.
We also have just recently introduced InReach service for optometry. It's a mobile service which has the capability for assessments on site. And the optometrist is from the Gold Coast, servicing all of the far North Queensland region, which is a huge area. He was going to touch base with you, Kieran, I think, to look at digital equipment that enables the registered nurse to take photos of the eye, like similar to what he would do in a face-to-face consult. And we can upload the images and send them to him as a pre-site consult. Wasn't sure if he'd touched base with you yet.
I haven't heard from him yet. This particular optometrist, we're in semi-regular contact. It's such an interesting and novel service that we are in turn presenting it to all the regions that we cover as a PHN. So I believe, Cairns and Mackay yet to come. We did Townsville first because he happened to be in Townsville at the time we were talking to him. He's he's definitely trying to do something very new and interesting, and always a lot of innovation coming out of him there. So it's such a interesting possibility. Yeah, I look forward to hearing more from him directly, but haven't quite just yet.
Sounds like a job for our geese camera, general imaging camera there, Kieran.
This fella's doing a lot of I'll be bringing that up because it's taken some really great photos of the eyes. I can never resist when I'm doing a demo of your cart, getting right up there and, doing that same trick you do, that glisten and the beautiful color that comes out of that is great. He's certainly doing some very in-depth stuff there with retinal examination and everything that might be beyond the capacity of of telehealth with our very specialized equipment, which don't know. We'll see how tight the PHN's purse strings are on what he's asking. All right. Anyone else feel like they have any further commentary on palliative care or anything while Helen's in here? No. Wonderful. I think the well has been dried. Like I said, I will pass out through those contact details through the newsletter, a bit of a summary of what we've talked to, all the valuable links to those echoes come out in the new training column that I've implemented in the newsletter. Upcoming sessions, I'll tend to be identifying whichever topic comes up next. I believe it was advanced care planning coming up in the next session. Helen, was it?
For
the palliative care echo?
Yeah, absolutely. Yeah. And
wonderful.
That's that national one. Yeah.
All the links will be shared for that one to join in on all the new stuff coming through. And I'll try and really make sure that the topic of Sparta is covered. Those contact details and everything to get in touch with your local hubs are identified through the newsletter, just in case you're not already engaging them to just improve your palliative care service delivery.
So have you got those, Kieran? I don't need to send those through. They're all from the Queensland Health site anyway, but
You
yeah.
grab those easy enough. Yeah, I need to do a bit of differentiating, talk to them. Their Cairns hub behaves very slightly differently, I think, to their Townsville hub. And then there's the factor of space as an additional service in there for the aged care homes. So I'll do a bit of delineation of responsibilities and try and get a summary published in the next release of the newsletter.
And look for the grief and bereavement one as well. I can send that through too. Yeah.
Yeah, very valuable service there, even as separate contact in many cases, I think, up here.
I think it is. Yeah. I'm trying to, yeah.
Thank you.
Thank you, everyone. Keep up the good work. It's well worth it. Patients love it. Bye.
Good, Helen.